the HDSA Center of Excellence. So as you all may know, the HDSA is interested in ensuring there is access to research and clinical care, no matter where one is in the United States. And so this partnership between ours and Dr. Aldred's will help to bring those opportunities to people within the entire WWAMI area. So we've been very excited about developing this relationship. And Jason is no novice to Huntington's disease. He's been a longstanding Huntington's disease clinical trialist and clinical practitioner. And so by way of introduction, I'll let you know that Jason had gone to undergraduate and medical school in Tennessee, where he's from, and then did his movement disorder residency at OHSU out in the Northwest here in Oregon. After which he went to Wisconsin for a period of time. And Jason, you were practicing and also starting to do clinical trials, and then realized that you needed to come back to the Northwest. So we were very glad that you did that. And now you have not only a clinic, but also an entire research program that's geared towards translational research, clinical trials, and movement disorders. So we are very glad to have you here today, and very lucky that you have partnered with us in our center's activities. So you can, I'll let you give you the microphone now, and welcome.
Well, thank you, Dr. Jayadev. Appreciate the introduction, and yeah, we've been very fortunate to have great clinical support and support staff here. We're at Selkirk Neurology in Spokane, Washington. We're a movement disorders clinical practice with the clinical trials division. Is there a slide set there that I think EJ was going to share on the screen? Go. Maybe just kind of that first, yeah, that's actually a fine one. Maximize that. Yeah, perfect. So yeah, I'm out here in Spokane, Washington with our clinic, Selkirk Neurology, and Inland Northwest Research, our clinical trials division. We've got a fairly small but focused practice on movement disorders, including Huntington's disease, Parkinson's disease. And I teach at the local medical schools here at WWAMI and the WSU program, and also the psychiatry residence more recently, which has been, I think, interesting and important to build that relationship for our HD patients and their families, and the internal medicine residents. So we're going to talk about some cognitive changes in HD today, and like Sumi was saying, and go ahead and advance to the next slide. So this is just a little bit about, kind of meet the doctor in the program. This is a bit about our program here. We kind of cover, again, for those of you, I mean, in the Northwest, everyone knows normally where Spokane is. Sometimes people think we're right by Seattle, and we're not, of course. But we cover from Central Washington, North Idaho, Western Montana. So we do pull people from those areas to our practice, because we're so very focused on movement disorders care, including HD. We have a deep brain stimulation program that we run for Parkinson's and other movement disorders, botulinum toxin program, and yeah, newly minted HDSA Center of Excellence partner site with our mentor site, University of Washington, and so soon we're really thrilled to be part of your team, and yourself and the other staff as well, social work and everything else, to make sure that we're delivering the best quality care that we can, cutting edge care for our patients, and have colleagues to back us up when things get hard. And then a bit about the research program. I'll tell a little bit about that. Go ahead and next slide. This is our what I kind of consider our provider clinical team here. myself, and we've got a psychiatric nurse practitioner, Megan Foster, physician assistant who focuses on movement disorders. These three, myself and these two individuals are at our site. Danielle Wald is a neuropsychologist who specializes in movement disorders neuropsychology, actually, and is part of our deep brain stimulation committee. And she's not at our clinic, but at Sacred Heart, and we have a very, very close working relationship with all of the movement disorder people in the area, but particularly Dr. Wald has been extremely valuable with diagnostics and the background in movement disorders has been wonderful. And then I don't have a picture yet, but Marissa Weiss is our brand new recently hired social worker, which we've fortunately been able to support with the generous funding of the HDSA as part of our relationship as a partner site with the University of Washington. So hopefully I'll have her on some of these in the near future. All right, next. Oh, and of course, our back office staff, I don't have any photos of them, but we have actually a 4-person nursing staff focused on really at this point, movement disorders nursing care, which is really, really neat. And I can talk a lot about the work they do, which is in many ways the backbone of our clinical program, but we'll focus on kind of the shorter topic today. Just a overview about the clinical trials division that Sumi mentioned. We have a CRC here, some info about it, and if you wanted to reach out. But we run phase 1, 2, and 3 clinical trials for movement disorders. My background, and when I did my movement disorders fellowship at OHSU, is I was focused on clinical pharmacology. What that means is the focus on the chemistry of helping to use medication, new medications, and discover new ways of bringing medication therapy to treat neurodegenerative and disorders, specifically movement disorders. So that was my focus and fellowship was clinical pharmacology. And I'm continuing to do that with our program here, running phase 1, 2, and 3 clinical trials. We're actually a remarkably high volume site. Most of our work is focused on Parkinson's disease, but we also do work in dystonia, essential tremor, and Huntington's as well. We've had a number of Huntington's trials and have one actively right now as well. We'll talk about it at the end of the program. And for the trials program, people actually come from all over the Northwest, even Canada. And what's neat about this is for clinical trials work, they're funded by sponsors. And so the sponsors actually cover travel. So that's just something to be aware of. And for those of you who have participated in the Signal trial at UW and other things, you're probably aware of that. But if you are interested in clinical trials, not just at our site, but any site, and be aware that a lot of times kind of funding's available. So if that's an issue, a lot of times that can be taken care of. And we focus on disease modifying therapies, gene targeting therapies, motor, non-motor symptoms of movement disorders, just improving symptoms in addition to the disorders, therapeutics that may slow progression. Okay. The next slide.
EJ, I may have distracted you.
Sorry, I'm trying to, it's not advancing. Hang on, let me keep trying.
Sometimes the arrow may work better.
Yeah, I'm using the arrow and the, hang on, I'm sorry.
It's okay.
Can you see it now?
Yeah. So this is just a short overview of goals. We're going to review a bit about cognitive impairment in Huntington's disease. Okay, yeah, that was the early one. Yes. So this is the triad, we call it, of HD symptoms. We can go back to that triad one. I can't remember which was first, actually. Yeah. There are 3 key features of HD: motor symptoms, excessive movement, chorea, and slow movement, bradykinesia, cognitive disorders, which we're going to talk about today, cognitive impairment, and psychiatric abnormalities. And so we kind of like to break them apart, break HD symptoms apart into this kind of triad, or these three different aspects. It kind of think helps us as providers understand them better and focus on them separately, and also talk with patients with them, focusing on this differently as well. So maybe make things a bit more clear. Okay, go to the next one. Cognitive impairment in Huntington's disease is a very important unmet need. The motor symptoms, in all aspects of HD, we have a long way to go to improve symptoms, but the motor symptoms and mood symptoms have, I would say, and I think most people would agree, at least some meaningful therapies that can improve symptoms in a way that drives improvement in quality of life. And until there's a cure for HD, that's what we're all about, trying to improve symptoms in a way that's safe, effective, and meaningful. And there are approved and FDA approved and not FDA approved options, and that's very common in how we handle conditions that are more rare, like Huntington's disease, compared to conditions that are very common. We kind of were reaching a lot outside of what is already available and approved. But for a long time, dopamine receptor blocker medicines, or antipsychotics, were the way, and still are, ways that we improve chorea, excessive involuntary movement, and now dopamine depleting agents like tetrabenazine and deutetrabenazine or Austedo are agents that are approved to improve the chorea, although they don't, for example, help the slow movement that can be part of HD as well. So you kind of have some benefits there. Mood symptoms, we don't have any therapy that's approved specific for Huntington's disease to improve mood symptoms, but we treat it as depression, anxiety, as we would for other conditions. And we have some success with that in HD, but still a lot of problems. I think the one glaring deficiency that I struggle with, and that I'm always is when you see it happening in patients and you see their families worried about it, is cognitive impairment, and that's probably we're most helpless as providers and have the fewest options when we're trying to deal with this part of Huntington's disease, because we don't really have good oral medication or other kind of other treatment options. We are always trying creative strategies, and as you'll see, you'll probably recognize, those of you that are kind of really living with people in your life that have cognitive impairment. You'll try anything that might work, and so that's where we get in the business of trying other therapies that have been approved for other conditions, maybe for HD, and hoping that'll work. And I'm going to kind of explain today why that's probably wishful thinking in many cases, but we are working on, the community is working on that, on agents that could improve cognitive impairment. And I think the trial that we'll talk about today is kind of interesting regarding that. Okay, next slide.
Sorry, I have to back out and go in again. I'm not sure what's happening here.
So I think one thing is we want to think about how is cognition impaired in Huntington's disease. It makes sense to try and slow down and look for patterns. What aspects are abnormal and what are normal are pretty good, and that's a standard strategy that neurologists like myself will and Sumi will we'll kind of look at what is working well and how can we maybe leverage that. How do we understand this? How to explain what to expect regarding thinking difficulties, cognitive difficulties for that patients are experiencing, so their family understands that and can prepare for those things. So speed of thinking, multitasking, inhibition of an unwanted behavior, apathy or indifference, emotional awareness or unawareness, and lack of awareness of problems like conditions. We call this anosognosia. There are significant glaring problems in cognitive difficulties that people with Huntington's may not even be aware of. These are major cognitive issues in Huntington's disease. Interestingly, recent and remote recall, that's our medical term for what a lot of people describe as memory, may be well preserved in Huntington's, even in very advanced stages. Memory is impacted in Huntington's disease, and there are memory problems, but they tend to be memory problems that have to do with learning new things. So abilities to perform tasks that were learned long before HD symptoms developed, it may be somewhat preserved, but if a person's working, for example, and there's a new aspect of their work that they have to do, there's something goes on that they have to troubleshoot problem solving, they have to learn a new way to work, they can't remember how to do that. So there's kind of a procedural memory problem that you will see with Huntington's disease. So it is, you know, it does have some components of memory, but I guess the other challenging part of this is there are people with Huntington's disease that you know have advanced movement problems and mood symptoms, but no real cognitive difficulties, and or they may have cognitive changes that could occur, you know, before the movement symptoms, or there's any mixture of these can kind of go together in terms of timing of cognitive changes. And again, I'm going to be contrasting other conditions that, you know, people may have heard about that are even more common than Huntington's to help ground our understanding of this. But Alzheimer's disease, for example, is a memory disorder, and memory is the thing that's affected kind of early on. Cognitive changes in HD may occur very early; they may occur much later, and so the predictability of this is challenging when you're trying to make plans. If you're worried about, you know, if you have symptoms, you're gene positive, and you know you're trying to make plans, you don't necessarily know what to expect or when these things may be coming, but that certainly they will come the longer it goes on. I mean, ultimately, everyone with HD will develop aspects of cognitive impairment. There will be significant movement symptoms and usually mood symptoms as well. So they all do kind of converge the longer you live with HD. Okay, next. And when we think about functional impairment due to cognition disorders, this is really where things start to matter a lot. It's certainly concerning if you're working or doing things with your family and your memory's not, or your cognition's not good, you're having difficulties. But then when it really starts to impact function where you can't do things or you need help with certain tasks, it transcends that, becomes a whole new degree of difficulty, an order of magnitude more complicated, and it really changes your life. So the change in capacity to manage work or finances, transportation, communication, self-care, this is the effect of cognitive impairment, really. And you know, as scary as it may be, you know, I was kind of trained, and I think most of the physicians working with HD are trained to, you know, be pretty direct and kind of try to confront this, and again try to understand what is working well with cognition, what aspects of thinking are good and what are impaired, and just, you know, going right at it and trying to find a way to maximize your ability to have a good life and function as well as you can. And I think it's important, it's very, very important for family members to understand, or coworkers and medical practitioners to understand that cognitive changes may be related to a degenerative disorder, and so it's important so that you know that we can focus on that as an aspect of HD. It's important to rule out other things. I mean, there could be other health issues, sleep disorders, you know, a number of things that should be considered. Thyroid disease and other things that could be considered that might, you know, worsen this as well. So we want to be mindful of that. So how do you find out if this is relevant for you? Well, you know, I kind of I wanted to shape this presentation based on kind of questions that I get in our clinic, in our HD clinic, work with our patients, and this is kind of what I think people will experience is you kind of start to find out, you know, through your primary doctor, perhaps, or probably more with your neurologist or movement disorder specialist. You know, is cognitive impairment present? We can kind of figure that out pretty quickly with basic testing, MoCA, MMSE. These are tests we use that are pretty quick to do in clinic. You know, at most HD centers, they follow the UHDRS. It's a Huntington's rating scale. The NIC tracks, not very specifically, but fairly consistent tracking methods of functional impairment due to cognition abnormalities. we really can make a good, much better understanding if we can have neuropsychological testing performed, know a lot more about what parts are good, what parts may be problems. Everyone comes to Huntington's disease with developing symptoms with their abilities, beforehand as well. So how are they? What was their cognitive capacity like beforehand versus after they develop symptoms? And then, we really try to go kind of right at the problem and ask, how can we make this better based on what's around us? And I like occupational therapy. That's, I think, a great option to try and improve the living situation, functional abilities. Can we be creative about solutions that are at hand? And of course, have a very honest conversation with family and care partners. And ultimately the goal here, this is kind of the hardest thing. This is what I really struggle with. I'm always trying to find a better way to do it is, how do we preserve autonomy and dignity for someone with HD who has cognitive impairment while supporting them? This is kind of like, the how do you watch a person and let them do, things, but yet not let them do something that's dangerous or do something that's financially harmful, or, and that's to me all art of medicine, and really just the only way to go about that is with conversations, continued conversations. Okay.
Jason?
Yeah.
Sorry, can I, this is such an important slide. I just want to go back to the neuropsychological testing. So, because that does come up, and it is a way, you were talking about earlier about trying to maximize what people do have and, build on that. Do you find that the neuropsych testing has been useful for your patients in that aspect? And also maybe just give people a sense of, this is the neuropsych testing is a couple hours, right?
That's right. Yeah. I mean, our neuropsych testing typically is there's
tell them what that is. And
yeah. So neuropsychological testing, you'll come in with a neuropsychologist, which is a specialized type of doctor. They're in the psychology kind of branch of things, but highly trained on brain function. And largely the role of a neuropsychologist is diagnostic. They don't typically do a lot of therapeutic type stuff, but they've got their work cut out for them, trying to find out, the what, the how, the when, and why, and stuff of cognition. So typically it's a 3-hour long test or so. The neuropsychologist interviews the patient and, very important, the care partner first, and then they select a battery of tests, a whole bunch of tests that are going to answer the questions that need to be answered. And then after that, they send them away and look at the test to kind of interpret it. And there's a lot of work in that too. And then we'll bring them back and explain it, and exactly tell them, what works, what's not, what are strategies. And importantly, I think a good aspect, if you can have the kind of consistency, is follow them over time. So annually, or maybe every other year, every couple years. It's not, I think, a really good time to, in my view, to get neuropsychological testing is when there's, ideally it might be at the beginning of the diagnosis. We don't really do that. I don't know if you guys do that or not. That's not, we don't do, but when there first starts to be cognitive difficulties that are, that have complex answers, or have heavy ramifications, working, childcare, things like that, and then following over time. So that's helpful, and I think knowing safety is a big thing too. When we get down to the last part, preserving autonomy and dignity is huge, right? I mean, that's a huge thing for HD patients and families too, because there's consequences of being a care partner and telling someone that, over and over and over again, well, I don't, we need to help you do this. That's a very complex relationship dynamic that, our patients and families, that's just they do it every day. So I think that the neuropsychological testing is important because it's the best thing we have. It's almost akin to having other neurologic symptoms and having a brain scan, and the brain scan's abnormal, and oh, well, okay, this is the issue. This is what's going on. And so I think the neuropsychological testing is akin to that. It's kind of like hey, we know what's going on. We know this is the issue. This is the problem. It's been tested. it's, you know, we know it. And so it provides kind of a hard stop, some certainty about what's good. And I think also, you know, to stress what's not good and what's good, you know, that's important too, because those are areas where a person can, you know, experience and appreciate more their autonomy in ways where they lose it in other areas.
Yeah, that's great. Thank you.
And then, yeah, next slide. Okay, so what's different about cognitive impairment and HD? So here I went kind of for a hardcore science slide. This is a brain. This is what appears to be probably a healthy human brain, I would think, labeled here. And I've got a couple conditions: Alzheimer's disease, Parkinson's disease, and Huntington's disease. And I've mentioned a couple different aspects here. If you can look at the top, you see C, that's the cortex. And that's the ribbon. It looks like a ribbon area lacing the outside of the brain. And in that cortex, that location in the brain, are cortical neurons. And cortical neurons are specific. They're different than the neurons that you see pointed out in the other areas of that slide. They're have very specific functions. Cortical neurons make us, you know, there are most human qualities, you would say, of language, memory, aspects of artistry, vision, things like that are refined there, really. And those nerve cells communicate with certain types of chemicals, lots of chemicals, really, neurochemicals. Acetylcholine's a big one. And in Alzheimer's disease, you have plaques and tangles that are associated with death of those nerve cells. So when you have that, you have a memory disorder, predominantly, with other aspects of cognition affected, and it progresses. And that's what makes Alzheimer's disease. Okay. Now, when you hear dementia, an umbrella term like dementia or thinking difficulties, you know, a lot of people think to Alzheimer's right away. They kind of interchange, the two are interchangeable for them, but they're really they don't mean the same thing. Dementia is a very broad term. It's a cognitive impairment where function is impaired as well, progresses. And Alzheimer's disease is by far the most common cognitive disorder related to brain degeneration. And again, these cortical cells, and actually not really where that arrow's at, but in the little area of the hippocampus, which is deep within the temporal lobe, are the cortical cells involved in that. In Parkinson's disease, which there are far more people in our clinic with PD than HD, as it is in many movement disorders clinics. Those are just a degenerative disorder where there's dopamine affected. And if you look at the very bottom left of that slide there, the substantia nigra, the SNC area there, that's the area where you have dopamine cells are dying. And that too can have aspects of cognition, although not really in that area so much. It can affect cognition a little bit in the dopamine cells in that area, but you see Lewy bodies that are contributing, as opposed to on Alzheimer's, this amyloid and beta, and Parkinson's, this Lewy bodies and the substantia nigra, and cognition's affected there too, but it's different. It's not like you see in Alzheimer's, and it's not like you see in HD. And so those Lewy bodies can be found all throughout the brain as Parkinson's advances, but it's specific, it's different. Okay, so this is a different type of thing. We have an FDA approved medication for Parkinson's cognitive impairment, rivastigmine, and in Alzheimer's disease, it's actually approved there as well. And in Alzheimer's, we have a few other approved agents. But those are, again, those are different disorders. And then we have Huntington's disease, and in Huntington's disease, different types of neurons are affected. And so the medium spiny neurons are abnormal in Huntington's disease. So these are different types of nerves, right? They're all in the brain. They're in different areas of the brain, and they have different functions. They all work together. And you could argue in very advanced forms of all these conditions, it gets messy, and many of these neurons are dying and stressed, and none of them are really probably working well. But there is a lot of specificity. So if you look at the STR, the striatum, if you look at that green structure right inside there, right deep in the brain above the blue structure, that striatum, that is the area that we first and foremost see death of these medium spiny neurons in Huntington's disease, and that's important. It's kind of like it's like a subway station with a lot of connections, and that's where we start to see all three of the triad of HD of mood and cognition and movement start to become abnormal. We think primarily because of death of those nerve cells in that green area, which is called the head of the caudate nucleus right there. Part of the striatum is the kind of the larger structure. And so this is important. And this is one of the reasons, this slide here is one of the reasons why we have approved treatments for cognition that help somewhat, I wouldn't say great, but somewhat for Alzheimer's and Parkinson's disease, perhaps, but not with HD, and why there's a huge need in this. And so this is, I want people to understand, why we don't have more than we have right now to offer for cognitive dysfunction in HD. And it's because it's different, right? It's a degenerative brain disease, but it's different. Okay, next slide. So we're going to dive deep a little bit for the next 2 or 3 slides about this, because I think our talking about Alzheimer's disease is a very good jumping off point, and we can kind of extrapolate to HD in a way. There are acetylcholinesterase inhibitors, donepezil, rivastigmine, galantamine are approved by the FDA to treat mild to moderate Alzheimer's disease, and they work by boosting acetylcholine and may improve overall cognition generally. For mild to moderate AD, they have, they're not what we're looking for ultimately, and improving symptoms anywhere near we really want them to be, and they have a relatively short-term effect in the grand scheme of a progressive brain disease. But they do work, and they've been shown to have an effect, and they boost acetylcholine, and acetylcholine is, we don't think of Alzheimer's disease as a acetylcholine disorder. It's a disorder where there's degeneration of nerve cells, right, in the cortex, and it's far more broad and far harder to get at than just improving elevating the levels of acetylcholine. But we have found that does help. Attention concentration tend to be areas that may improve more than other aspects with these therapies, but tolerability is generally good. So you'll find a lot of people, if you talk to people with HD, talk to their families talk to family. Oh, we've got he or she has memory problems. Well, try an Alzheimer's medicine. That's not really what we recommend actually at this point. There's nothing wrong with trying that off label. I mean, I understand why people do it, but this is not really the same thing. And so like with Huntington's disease, ultimately what these conditions share is that meaningful Alzheimer's treatments will involve therapy that slows progression of death of nerve cells and memory, language, perception, and many other areas. We'll come back to this at the end. Okay. Uh-oh, slipped ahead a little bit. I'm going to go back. Okay, yeah, okay, yeah. Just go one more forward then. Perfect. And so, so how do we know this? Well, Esther Kubo, who is a Spanish movement disorders neurologist I've worked with on some other projects, wrote a nice, or did a nice project, small proof of principle project with Kathy Shannon, who I think was at Rush at the time, looking at 30 patients that were randomly assigned to treatment with the donepezil or placebo. There was a small trial, but they did not find any improvement in Kriya, cognition, or quality of life, and they had some mild adverse effects, and determined that donepezil was not effective for treatment of Huntington's disease. So this actually has been looked at. That's a small study, not typically what we look for. The size we would look for to definitively rule in or out a therapy as being meaningful or not. But it's one that's been done and done in a published in neurology journal, so in a peer-reviewed journal. That was vetted. So that's very meaningful project to be aware of. And let's go to the next one. And then there was a review of up to as of 2013 projects that were looking at acetylcholinesterase inhibitors, these treatments that we use for Alzheimer's disease, right? Because we have this for Alzheimer's, it's approved, so let's make sure. And so there was they looked at 6 articles looking at different trials of different types of Alzheimer's treatment, and found limited evidence for the use of acetylcholinesterase inhibitors in cognitive impairment in Huntington's disease. So again, not very supportive, for trying Alzheimer therapies in HD. Again, if your providers mentioned it or recommended it, that's a decision that you guys have to think about, but this is kind of what we've known so far about these AD meds. And lastly, there's a medicine, Memantine, which is approved for Alzheimer's disease. And there was a study by Bill Ondo down at Baylor that basically found no improvement in behavior or cognitive symptoms. There was maybe a mild improvement in motor symptoms in HD. This is not something that I use often for any motor symptoms in HD, but yeah, it appeared to be well tolerated. It is, of course, approved in Alzheimer's disease, so the safety has already kind of been established, but really they were kind of hoping to see improvement in behavior or cognition, and there was none. So where does that leave us? Well, it leaves us with the idea of, as far as we know, as much as it's been looked at, Alzheimer's medicines are probably not really going to be useful for cognition in Huntington's disease. And I think that's important because there's a lot of people on these medications for Alzheimer's, which is, appropriate. But, we have to be mindful that these medicines could have side effects. They have not been studied a lot in Huntington's disease, and there's potential they could worsen cognitive or behavioral symptoms in Huntington's, and we just don't know that much about them, but there's certainly not a lot of positive evidence for them in HD. Okay. And this is kind of a technical slide. I just wanted to kind of use this as a general point about, clinical trials in Huntington's disease. And this is, one of the things that's so exciting to me to be involved in Huntington's disease research is that we have a target gene, we have a target protein, we know how to diagnose patients. We have a lot of people, early diagnosis. We have, these trials, following HD patients early on. And although we haven't had any trial positive showing that we can slow the progression of HD, we've had a lot of really good ideas, I think. But really, I think with Huntington's disease, one of the reasons we probably haven't had more trials focused on symptom treatment in HD for cognition is that everything's so very focused on slowing disease progression. And I think that's a pretty defendable idea. I mean, we know that really what we're going for is slowing progression, early treatment, things like that. But I think that at this point, after the collective, the Ionis trial, many of you are following the Ionis Roche trial, and after the collective depression in the Huntington's community that many of the providers experienced after the negative Ionis Roche results, I think that it really does behoove us to consider, continuing to focus on disease slowing trials for HD, which would, by definition, they should slow cognitive impairment. They should slow progression of mood disorders, perhaps, and movement disorders in HD. But we really do need symptomatic therapies as well. I mean, it may very well be that we'll find a great disease modifying trial, but it will slow progression, and we'll still have to contend with symptoms. So it's important that research continues to focus on this unmet need. Okay, next slide. All right, here are our final two slides of the presentation. This is the Dimension study for a compound Sage 718. This is a chemical. It's an endogenous steroid that's basically you give it and it works. For a steroid, by definition, kind of works far away from its initial site of engagement. It's a type of drug that's called a positive allosteric modulator of the Nmda receptor. Let me translate that for our patients and families. So what that means is it affects this receptor called the Nmda receptor. And I don't have any material on this, but the Nmda receptor, this is this medicine, Memantine, that is used in Alzheimer's, works at the Nmda receptor as a blocker. And this is a well-established receptor or part of the physiology, the chemistry of how the brain has been shown to process parts of cognition. And particularly this work, I can tell you, I was looking at some of the background information last night. This work is heavily based on the clinical science on this work is heavily based on schizophrenia, work in schizophrenia models and human trials in schizophrenia, as well as ADHD, which I think is interesting because, I was thinking about it, and, there are aspects of cognition in Huntington's disease that, that I can see how that they involve, attentional deficits and perhaps, behavioral abnormalities that are, sometimes reminiscent of those two other conditions. And the idea here is that it would act at this Nmda receptor and change it kind of indirectly. It doesn't go right to the Nmda receptor, kind of binds off site. They call that allosteric modulation. And so that's kind of a novel. It's new. That's not something that's been tried before. And then it has some solid foundation in the science of other medical conditions that have clinical features that are reminiscent of HD cognitive disorders. And it has it doesn't have this is not a therapy that's looking to have like an immediate effect. It has what we call in neurophysiology is called long-term potentiation. And what that means is you're treating a nerve cell, and it kind of changes how the nerve cell fires with the other nerve cells it works with over kind of a longer term, over days or weeks or something like that, and in a way that may be helpful for learning and memory. And I thought that was really very interesting because again, our immediate recall for things in HD may be okay, or long-term recall, but people in HD really do have been shown to struggle to learn new things once the symptoms become very prominent. So I thought that was very kind of an interesting concept up there too. And again, this is not something that appears to be, they're working on improving symptoms in a pathway that's not specific to only HD, but you can see in cognitive dysfunction in people with overall neurodegenerative diseases. And this is in some ways kind of an out of the box idea. For a long time, much of clinical symptomatic treatments for neurodegenerative disorders have really been focused on things that are highly disease specific, and that's important, I think, particularly when we're thinking about slowing the progression of conditions. But when you have aspects of cognitive impairment in Huntington's disease that other neurodegenerative disorders may share in some ways, even though they're different, that showing that it may have potential, for example, in Alzheimer's disease, is being looked at in AD, as well as Huntington's disease is an interesting thing. All right, and then the last slide here I have is just an overview of the trial, which we're running at Inland Northwest Research. This is a dementia study, SAGE 718. I'm not going to go through all this, but this is all available online. All the material I've presented is publicly available. And so it's a double-blind randomized placebo-controlled trial looking at what we're ultimately trying to measure are changes in the Huntington's disease cognitive assessment battery. So we're looking specifically for improvements in cognition, which is different than disease-modifying trials in Huntington's disease, where you're typically looking at motor or total UHDRS changes and Huntington's changes. This is in phase 2 development, so this is something that's had some early vetting and safety study, but has not had yet been through phase 3, which is our final stage of clinical testing to show bona fide, robust benefits and safety. So it's kind of an intermediary, but the good thing about that is that it's not a very long trial, so it's kind of like 4 or 5 month trial and in length, and so that's kind of what this project's about. So feel free to review that material, and that's it. I've got a question slide next, and
yeah, it's really interesting and exciting to think about medications that are targeting cognition. Jason, I think it's really it's not something that we probably talk about as much. And I think the gene lowering drugs hold great promise, but going about it in parallel, trying to promote neuron resilience, neuron resistance, or at least slow damage, is going to be clearly an important part of the whole therapeutic cocktail. So that's pretty exciting.
Yeah. Well, we'll see what comes from this, and kind of trying to tackle this along with all the other aspects of managing HD is, it's a lot, but I think there's good reasons to be hopeful. It's encouraging. When we saw this project come up, I was kind of surprised. Like, wait a minute, that cognitive trial for HD for symptoms? That's not normal. That's not something we hear about a lot. So it's kind of very encouraging that there's efforts in that area.
Right, right. I understand there's a working group as well to try and bring the cognitive deficits into the diagnostic realm so that you may know about that.
Yeah, I've not followed that closely, but I'm aware of kind of particularly the early, we have the idea of kind of pre-manifest HD. And so when we talk about, manifest HD, that's the kind of the clinical term or clinical trial term about, you're definitely, a person is symptomatic. Well, I mean, that's easy to do with the movement disorder piece relatively. I mean, when it's cognitive or mood, it's much harder. And the challenge is that a person, we may be missing patients that are actually manifest or, that they check the HD box more with the cognitive disorder. And so that I think could be part of it. Kind of having a very clear criteria for a cognitive heavy clinical symptom set for HD patients that may not be showing motor symptoms.
Right, right, absolutely. Interesting. So if no one asks questions, I'll just ask some questions. So the neuropsych testing, is that generally covered by insurance? I know in the memory clinic it often is. I don't know if that's been your experience.
The neuropsychological testing for Huntington's disease is typically covered by insurance. I think it's important that the referral for neuropsychology includes cognitive impairment in there. If a referral is made for Huntington's disease, there may be certain commercial payers, that are Medicare even, that would not cover that or would not approve the referral. But I will usually, be specific cognitive impairment. And use that. The diagnosis codes are kind of funny about how our medical record system. I can put Huntington's disease cognitive impairment, and it'll pull that up, but really it's pulling up an ICD-10 code that's like, it doesn't necessarily make sense to me, but it falls under that category. So I think in short, usually it is covered. If, like we were talking about, if there's a need, if there's a functional need, if there's a work-related need, boy, it's, I think, totally worth the 2-day, couple-hour-long visit to have that baseline at least.
Absolutely, yeah. So how many trials right now do you have running?
We have about 6 trials actively recruiting right now. We have trials that are in phases of opening and closing, continuously. Those can be kind of slow to open, slow to close. So we've got about 6 trials enrolling. We had 2 HD trials going at the same time. We had our Connect HD and Triplet HD, which is looking at basically gene stabilization. It was an observational study looking for potential gene stabilizing therapy for triplet repeat disorders broadly. But the phase 1 on that was a pre-phase 1. The phase 1's been put on hold right now, so we're kind of waiting to see what happens with that. And then the Connect trial, we're no longer, that was closed. And then so the SAGE trial is the only HD trial we're doing. We've got 2 essential tremor trials and 2 or 3 Parkinson's trials.
Right. Yeah, it's kind of unfortunate. I think some of the FDA's unusual decisions as of late, I think they seem to be fishtailing a bit about being less than rigorous with some drugs, and then in response, perhaps being more constricting.
Yeah, I think that to your point, the Alzheimer's therapy approval for Aduhelm has been very controversial, and I understand both views, but ultimately we have to have like fidelity and honesty about what we're getting for these, you know, potential therapies. And so on one end, and the HD community is no stranger to this, you know, the sense of urgency and the sense of you know, the devastation that HD brings in midlife, you know, midlife,
Exactly.
not the weight parts of life that being more valuable than the other, but midlife as opposed to later life, and the lack of disease modifying therapies, et cetera. So the HD community knows this well, but having a therapy out there that doesn't ultimately make a meaningful difference, and you know, or has a very, very mild questionable benefit with significant cost and or safety risk or issues is a problem. And we just have to, I think we just have to kind of keep the conversation open. And I think the transparency piece is huge. And so hopefully we can learn from some of the recent kind of controversy in the Alzheimer's world with you know, this with the approval of Aduhelm and kind of what's going on with that. You know, I think you know, even those things can be positive if, you know, can kind of learn from it. We certainly don't want that happening in HD. We do not want that. It does nothing in that way but kind of distract us from the goal. We got to keep our eyes on the prize. And I mean, I don't know about you. I don't know what you think. I'd be curious to hear your thoughts, but I think disease modification in HD is a given. It's just a matter of time. And you're a geneticist. You know.
No, I completely agree. I think that we're dealing with, I mean, now you and I are probably just talking. So, but I mean, I think it's a
fireside
delivery.
chat.
Yeah, exactly. I think it's a delivery issue. I think, you know, it's going to be multi-pronged. And I do think that doing the, you know, the triplet approach of trying to also mitigate the effect of having the cell's response to the expansion is another piece of the therapy. And I think we'll get there. It's just when. I completely agree. And I think it's probably going to, you know, once we get over some of the technical hurdles in one disease, we probably will be successful in a number of these genetic diseases.
Well, yeah, and I think you might be able to say some words on like the SMA therapies, you know, spinal muscular atrophy. I mean, so, you know, that you know, these are like pediatric ALS basically, right? More or less. And
Yeah.
just some of the stuff, the genetic therapies that, you know, we always would, I mean, we're not that old, but, you know, we're like, oh gosh, I hope I live to see some of these really things. We know that's just possible. So I'm hopeful. I mean, it's hard to see, you know, visit after visit with patients where they've really struggled, but I'm hopeful. And I think it's important for patients and families to know that genetic therapies, that we are starting to see this. I mean, this is happening.
Yeah, that's true. We have successfully done this, and it is modifiable, the gene level of something that's causing neurological disease. Absolutely. Yeah. Yeah, it's coming.
Yeah.
But we'll be thoughtful about it.
Yeah, think good thoughts. That's what I try to do.
Yeah, exactly. Do other people have questions besides me and Jason just talking? So I imagine, Jason, if people have questions, they can contact your center, they can contact our center. And we were talking earlier, you and me and AJ, about the value of having in-person education seminars. And so we probably will get that going over the next 6 months or so. But for now, if people, so EJ, if people want to refer back to this talk, which I thought was extremely helpful, very interesting, and a great topic to discuss the cognitive changes, something we don't do enough. If people wanted to go back to it, EJ, we can find it on the chapter website, and I imagine we'll be able to put it on the center website as well.
Yes, we'll have it on those two spots, as well as all our social media outlets.
Fantastic. Fantastic.
And thank you everyone for your patience on the slides.
EJ, thank you for your emceeing.
post after the session is over. If you do have questions for Dr. Aldred or Sumi, just send it to my email. I have it in the chat box, or reach out to them directly.
Please do.
Yes.
All right. Thank you, Jason. That was just fantastic hour.
Thanks, Sue. Thanks for having me.
Okay. See you soon. Bye.